And with that, I would like to introduce Dr. Muir. Dr. Muir is boarded in veterinary anesthesiology. He's made a tremendous amount of contributions to the profession, both in anesthesia and really been instrumental in developing pain management for our patients. So thank you for all you've done. And really, Bill, thank you for the opportunity to educate us tonight. And with that, I'll let you get started. Thanks so much.
Great. Well, thank you, Anthony, and good evening, everyone. I know it's not that late on the West Coast, but I gave this presentation earlier this evening to people on the East Coast, so I've had a chance to practice as well as answer some questions. Tonight, we're going to talk about anesthetic mishaps and mistakes. And based on the number of years I've been doing this, I've probably seen them all, at least certainly the majority of them. So been there, done that. I would like to also emphasize that a comment by John Wooden couldn't be more true. It's that it's what you learn after you think. It should say, you know it all, that counts. And the reason is because your knowledge based with your clinical experience goes a long way to not only understanding what can go wrong, but also how to take care of what goes wrong, which is what we're going to talk about this evening. Last but not least, every anesthetic related decision is dependent upon context. That is to say that you wouldn't treat an old, potentially obese, potentially diabetic, or an animal with comorbidities, dog or cat, the same way that you would a young, healthy, let's say normal physiologically dog or cat. So you need to put it in the context of what you're dealing with as to what you will do with regard to treatment, not only with regard to anesthetic drugs, but also with regard to, let's say, therapeutic drugs that help prevent or treat mishaps and mistakes. Suffice it to say, there are no safe anesthetic drugs, there are no safe anesthetic techniques, there are only safe anesthetists. So one of the things that I've introduced over the years is what I call the AQI, or Anesthetic Quality Index. And I'll make my slides available to Dr. Berkowitz in a PowerPoint if you want to go over them sometime in the future. I introduced this initially at the Animal Medical Center when I was there, but I refined it somewhat and added to it. But it talks about, I have the individuals doing anesthesia just check off where they had problems, either before anesthesia, intraoperatively, or postoperatively. And then periodically, monthly, we'd sit down and go through this and see if there was anything that was consistently not going as well as we wanted to, and therefore identify the problem so we could address the problem and basically do something to make it go away. You might notice in these slides that somewhere on the bottom, either on the lower right or left-hand side, there will be references for those of you that want to read further about some of these topics as we go through them. Now, generally, anesthesia is associated with side effects that might be more prominent in certain breeds of animals or in certain species. For example, brachycephalic breeds are noted for upper airway obstruction. Sighthounds are known for having, let's say, greater response to drugs than other animals. This might be due to the fact that they have lower body fat and are predisposed because of that to hypothermia. Herding breeds are known to have the MDR1 mutation, which prolongs the metabolism of certain anesthetic drugs. Toy breeds are subject or predisposed to hypothermia. They may also be predisposed to hypoglycemia. Certainly certain breeds of small or toy breeds like the Brussels Griffon are predisposed to cranial cervical junctional abnormalities. And these small dogs, it basically says you have to be careful during oral tracheal intubation so that you don't end up with a paralyzed patient. Giant breeds of dogs are predisposed to atrial fibrillation, as well as increased response to certain sedatives. Doberman pincers, boxers to cardiomyopathy, Doberman pincers particularly though to von Willebrand's disease or clotting abnormalities. And cats, certainly most cats that are aged or senior have some evidence for chronic renal disease. Some certain breeds may have cardiomyopathy. So you need to think about this and possibly discuss it during your hospital meetings so that everybody is aware of things that potentially could predispose the animal to some anesthetic associated mishap or mistake. This is particularly true with senior animals. A lot of dentals get done, and you need to take that into consideration with regard to whether or not they're obese, whether or not they have heart disease, renal disease, osteoarthritis, etc. So what you'll find in today's world, and I think it'll be adopted into the veterinary world since there's papers already being published, is this issue of a frailty index. Because the frailty index usually relates to the animal's sensitivity to anesthetic drugs. So keep your eyes out for this. These frailty indexes have already been developed for dogs and cats. You can see a paper here written with regard to a frailty index in dogs. So this helps you in the context of deciding which drugs you will want to use. Again, obesity, you have to think about the animal based upon their lean body weight. So what does obesity mean where it actually affects drug dose? It usually means an animal that's somewhere between 20 and 30% overweight. The human literature suggests they have to be over 30% overweight in veterinary medicine, primarily because dogs and cats are harder to anesthetize than humans are. And what I really mean by that, that humans are more sensitive to the anesthetic effects of drugs than dogs and cats are. You can almost, and in some instances, you can anesthetize a human with nothing more than a benzodiazepine, midazolam or diazepam. And if you've ever had a surgical procedure and somebody has administered you midazolam, you know what I'm talking about, because it puts you in a state of what's called twilight sleep. That is, you kind of know what's going on around you, but not only don't you care, you can't really respond. Where that's not the case with a dog or a cat. That is, you can give them fairly stiff dosages multiple times on the basis of body weight, which you would give to a human, and still not produce twilight sleep or anesthesia. So humans are more sensitive to anesthetic drugs, easier to anesthetize than dogs and cats are. Obese animals are predisposed to respiratory problems. They usually have an increased respiratory rate because their chest wall is stiffer, and it's easier to breathe faster than it is to breathe deeper. So they have a tendency to hypoventilate, to develop ventilation perfusion abnormalities. Basically, what that says is to develop hypoxemia. And that's because blood flow isn't distributed to the areas of the lung that are well ventilated. So you might think about these issues in the context of predisposing to some type of adverse response to your anesthetic protocol. First of all, remember, always check your anesthetic equipment. And here's a website that shows you or provides you a checklist. Always perform a leak test. Close the pop off, turn up the oxygen flow, watch the bag fill. Make sure that the bag will support a pressure of at least 40 centimeters of water. You should never really need to develop that much pressure in the circuit when you're ventilating them or squeezing the rebreathing bag. But this is something that you want to be able to be sure that the circuit will support 40 centimeters of water pressure, so that if you have to, you can at least give 20-25 centimeters of water. And it also tells you if your circuit is functioning properly. If there is a leak, it's most likely at the bag. Here's a bag that looks normal, but when it's stretched out, you can see that there's these micro holes, which I've made bigger by pulling on the end of the bag. So there could be a leak there, but the most common place for leaks are either at the CO2 absorber canister, because the seals aren't properly setting or associated with the endotracheal tube cuff. So always remember to check that. In today's world, we're trying to have fear-free clinics, and Marty Becker's book goes through that in great detail, so it's always a good read. But what we're trying to do is to minimize anxiety, stress, and fear in animals, because a survey was done. Actually, I conducted a survey amongst a number of hospitals that involved several hundred animals, and at least based on the questionnaire that I used, at least 17% plus of dogs have some significant degree of fear, anxiety, or stress, and over 30% of the cats. And that's probably, a conservative view, depending on how you structure your questions. Well, what are the causes? All the obvious ones. Certainly, strange environment, inadequate socialization could be one, but strange sounds, strange smells, strange animals, strange people, all of these things compound to create anxiety and stress in animals. Well, why is that important? Because anxiety and stress activate the neuroadrenal axis and force you to use more drug to produce the desired effect. And that's anesthesia, or saying that another way, is unconsciousness from which they cannot be aroused. That is, you don't want them waking up during whatever medical or surgical procedure that you're performing. So these things all turn out to be important. Now, anxiolysis or calming. Basically what it says is that all animals, even those that, let's say, are a little more frail, need pre-anesthetic medication. Those that are the most frail require less, as opposed to those that might be a little bit obnoxious or wound up because they need proper sedation with analgesia. But what this does, that is this pre-anesthetic medication, is it reduces the dose of the potentially more dangerous drug. And compared to your pre-anesthetic drugs, the intravenous and inhalant anesthetic drugs are the more dangerous. That is to say, if we did it on a comparison basis, the dose required to produce an adverse effect is a lot lower with your injectable and inhalant anesthetic drug than it is with regard to your pre-anesthetic drug, let alone many of the pre-anesthetic drugs have antagonists. So whatever drugs you're using for pre-anesthetic sedation or analgesia, make sure that you always have the antagonist, when it's available at the site, so you don't have to go hunting for it should you have an adverse effect. So anxiety and stress are indicated by pacing, trembling, shaking, hypervigilance, panting, lip licking, frequent yawning, so on and so forth. Here's a cat that's drooling, and here's a video of a dog. You can see it's almost stuporous because it's so terrified about what might be happening, and you can see the drool. Here's an older schnauzer, and you can see the ears shaking. This dog is stressed. It had come in for a dental, but again, high anxiety. Here's a younger mixed breed dog, but you can see the rear legs shaking. These are all signs that these animals are going to take more drug than they would have otherwise, unless you can adequately remove the anxiety, stress, and fear associated with the strange environment or whatever is making them anxietous in the first place. Pain is certainly a big factor. Here's a dog that came in probably about an hour before I got to it, before it was going to be anesthetized. And so when you hear whimpering and howling and so on, you got to provide enough analgesia to make the animal comfortable, as well as to reduce the amount of injectable drug. Here's a dog with osteoarthritis of the hips. You can see it's almost standing on its front legs, trying to take the weight off the back leg. The mouth is open, the animal is panting, etc. So all these things are tip-offs that unless you properly pre-anesthetize the animal, that you're going to be using more drug than you need to in order to induce as well as maintain anesthesia. Certainly fear is an issue. Here is a guard cat, at least that's what I call them. Animals that respond adversely to manipulation or handling, animals that are panting, animals that look away. All these things are indications of either fear or pain that needs to be eliminated before you induce them to anesthesia. Now, anxiolytics. Well, there's a lot of drugs with known anxiolytic activity. Acepromazine is one. This can be used certainly in normal, healthy animals. People like to avoid it only because it has a long duration of action. But these are all oral medications that people have used prior to surgery, either the morning of and even sometimes the day before. Trazodone has now become popular for this purpose. Remember, however, this is a serotonin norepinephrine reuptake inhibitor, so it can predispose in those animals that are susceptible to serotonin syndrome, which generally, if it gets severe, needs to be treated with beta blockers. But this is something that, at least for most normal, healthy dogs and mixed breed dogs, seems to be effective as an anxiolytic. I'd be careful with it in herding dogs, only because of the issue of serotonin syndrome. Gabapentin has become very popular, given to animals a day ahead of time, and certainly the morning of. Dosages of 10 to 30 milligrams per kg in dogs, 100 milligrams per 100 milligrams total in, let's say, 2 to 3 kilogram cats. It's a very safe drug, but it does produce somnolence, but it also has anxiolytic effects. Most recently, cannabidiol has been used, or CBD, but there isn't enough research yet to support its value as an anxiolytic, but most people have noted that it does have a calming effect, at least when the dose is initiated somewhere in the neighborhood of 24 hours before the surgical procedure. I'm not going to go into a lot of detail about drugs, at least based on the first seminar, because the reality is I'm not here to talk about drugs. I'm here to talk about the consequences of drugs. So oral dexmedetomidine can be used as a anxiolytic. So it's 20 to 40 micrograms per kg PO. Usually the advantage of this is it does produce adequate sedation if given at least an hour before the surgical procedure. Owners can give it before they even come to the hospital if you have a good association with the owner. And it's potentially reversible if something were to go wrong. I can tell you in my 15 to 20 years of using oral alpha-2 agonists, I really haven't had a problem. So ketamine can be given IM, although most people don't like to give it because of the pain associated with its use. And then there's different combinations that people have used to produce, let's say, more pronounced sedation before surgery. Dexmedetomidine ketamine, dexmedetomidine hydromorphone ketamine, TKX, or sometimes now people have used TKD to mobilize animals that were mean or aggressive. This is a pretty potent cocktail that'll knock an animal out for about sometimes up to an hour, 40 minutes to an hour. And I would say most recently, and it doesn't hurt when you give it IM, is the combination of alfaxin intramuscularly with, again, other drugs like butorphanol, as well as the alpha-2 agonist dexmedetomidine. This is becoming more popular as people use it. Excellent, let's say, anxiolytic sedative combination given intramuscularly prior to induction. Cut your induction dose of propofol or alfaxin, sometimes up to 70%. So this is something else to consider as far as the drug combination. As far as NSAIDs are concerned, I don't recommend giving them before surgery. You certainly can do it without a whole lot of concern in otherwise normal healthy animals with normal renal function. But when you're dealing with higher risk animals, or let's say protracted surgeries or older animals, then you set yourself up for a potential renal impairment of some kind. The NSAIDs, when I use them, I prefer robenacoxib based on its safety profile. And I give it once the animal has recovered and normal physiologic function has returned, and that includes then the maintenance of normal heart rates, blood pressures, and blood flow to the kidneys. So always remember that renal impairment has been observed in 8% or greater of older dogs and about 50% or greater of older cats. So think about that when you're anesthetizing an animal. So what are the most common problems that are seen in association with anesthesia care in dogs and cats? Well, here they are listed. There's been several surveys. This was one of the first surveys that was done by McMillan and Darcy. But there have been several surveys since that point to arousal and breakthrough pain. That is, the animal wakes up sometime during the anesthetic procedure or shortly after induction, hypoventilation, hypotension, arrhythmias, airway complications, recovery delirium, and that's at about 7%. I would say it's probably more than that in some hospitals. That's why I introduced the idea of an anesthetic quality index, because at one point in one of the hospitals I was working at, I would say about 20% of the animals were having some kind of recovery issue. So that may or may not relate to delirium, but that issue usually leads to delirium depending on how fast the animal is recovering from anesthesia. Aspiration is a potential problem. Seizures can occur. And I would tell you, although it's not common, you can see here it's not listed as very high, is that any anesthetic has the potential to cause seizures. The mechanisms are often obscure or unknown, but this has been reported for both propofol and alfaxin, even though both those drugs are known to be anti-epileptic, particularly propofol. Regardless, in some dogs and cats, the administration of propofol or alfaxin can introduce or cause animals to develop myoclonus, and a situation which is intermittent myoclonus, and sometimes that's called jactitations, that is where a limb will start to spasm or jerk. And last but not least are drug reactions. Again, like the herding dogs that might have MDR1 deficiencies, and there are MDR1 genetics, which lead to prolonged metabolism of some anesthetic drugs. So you got to ask yourself, how does your hospital compare? Remember that anesthetic mortality is higher in most animals than it is in humans. And part of the reason for that is that it takes more drug to produce anesthesia in animals than it does in humans. That is, animals in general, at least most animals, are more fight or flight and have a better stress response than many humans. Like I said, you can almost anesthetize, and in fact can anesthetize some humans with benzodiazepine, like something like a dose of midazolam, and you can't do that in dogs or cats. In fact, lower dosage of benzodiazepine in cats, as many of you know, can cause those animals to become harder to work with and harder to handle, which was shown by Steve Haskins probably now 20, 25 years ago. How larger doses, usually don't see that, but most people only give about 0.1 or 0.2 milligrams per kg, which in the dog is okay, but not in the cat. Again, I'm not going to talk a whole lot about drugs, just make some inferences as we go through. And now we'll start to talk about these anesthetic problems that occur or are common in dogs and cats. So arousal during anesthesia causes inadequate sedation, inadequate hypnosis, that is, they're not unconscious enough, inadequate analgesia, and inadequate ventilation. Now, this is particularly true with inhalant anesthetics. Why? Because what's the drug delivery system for an inhalant anesthetic? It's the lung. So when animals don't breathe properly, that is, don't breathe often enough or deep enough, that is, exchange enough gas volume, they don't take up the inhalant anesthetic to the degree that they should. So what do you find yourself doing? Well, the animal's getting lights, so you turn up the vaporizer. So the animal finally goes to sleep, because in fact, when you turn up the vaporizer, you're also probably manually ventilating, at least occasionally, if not consistently. So finally the animal does go to sleep or is induced to anesthesia. But because you turned up the vaporizer and began to bag them, now you know that they now notice that the animal isn't breathing very well, so you have to continue ventilation, or that the animal has to become mildly, if not more than mildly, moderately hypotensive. So the question is, how do you avoid that? And we'll get to that in a minute. So here are some of the drugs that are used to produce analgesia and anxiolysis and sedation. I just want to make a couple of points. And that is, one of the more popular drugs, based on its versatility and the fact that it doesn't induce histamine release like morphine does, is hydromorphone. Yes, it has the potential to produce hyperthermia in cats, but that's a dose-dependent phenomena. And when it's used in combination with very low doses of alpha-2 agonists, and by that I mean specifically dexmedetomidine, at microgram doses, 1 to 2 micrograms per kilogram, you get excellent anxiolysis, excellent sedation, as well as a synergistic effect. So very low dosages, microgram dosages, about 1 to 2 micrograms per kilogram with about 0.1 milligram per kilogram of hydromorphone is excellent for most, let's say, normal healthy dogs and those that are a little bit too happy to see you, to calm them down and produce a good sedative effect. Otherwise, with age patients, it's combination hydromorphone with midazolam is excellent. And although benzodiazepines aren't noted for their analgesic effect, when used in combination with hydromorphone, because of their muscle relaxant effects and their central nervous system effects, they do minimally improve the analgesia of hydromorphone. Whether that's clinically relevant or not has yet to be determined. It's minor regardless, so even though there might be some effect, it may not be clinically relevant. You'll still be dependent upon the analgesic effects of hydromorphone to get what you want. For intraoperative pain, we usually depend on more potent opioids like fentanyl. And then for induction anesthesia, the more popular drugs, although ketamine or Ketval could be used, but because of the relaxant properties are propofol and alfaxin. And remember, I said that all anesthetic drugs are potentially capable of inducing a seizure, and those have been reported with both propofol and alfaxin. That is, not only seizures, but mild clonus. Mechanism, for the most part, unknown. Treatment, about the same situation, other than people have said that you should give them an additional dose of a drug that acts similarly, but isn't nearly as potent, and that's the benzodiazepines, either diazepam or midazolam, and most people have used midazolam. Again, they're all, quotes, GABA-A agonists. That's their mechanism of action. It's just alfaxin and propofol are much more potent than the benzodiazepines. They don't act at the same site within the GABA-A receptor, even though that's where they act. They act at the GABA-A receptor, but at different sites within that receptor. And because of their anticonvulsant effects, the additional dose of the benzodiazepine should help these to go away. Otherwise, it's supportive care. That is, if you can, intubate them, or at least put an oxygen mask on them, and the effects usually subside or go away within about 5 or 10 minutes. But these seizures sometimes get pretty severe. I've witnessed them myself, particularly with propofol, and usually when I give them an additional dose of propofol, they go away. So quite honestly, it's an area that needs further investigation. And even though these drugs are in and of themselves anticonvulsants, you sometimes will see these situations occur during induction to anesthesia. Inhalant anesthesia, well, isoflurane is by far the way the most popular, but my preference is sevoflurane for two reasons. Number one, it has a higher therapeutic range, and number two, it's easier to control. That is to say, if you remember back, it's less soluble in the blood, so that means faster induction, faster recovery. So it means if I did get into trouble, I could get out of trouble faster. I'll just repeat one more time that the best way to maintain stable plane of anesthesia is to control breathing, either manually or mechanically. And if you're going to control the breathing with a ventilator, I recommend a standing bellows as opposed to a hanging bellows. And the reason is animals can breathe normally with a standing bellows, as opposed to if it's a hanging bellows, they need to develop enough effort to lift the bellows in order to take a breath, and that doesn't always happen. The ideal end tidal CO2 should be somewhere in the neighborhood of 40, and we'll come to that in a minute. Last but not least, always remember to use calcium carbonate or carbolime as a CO2 removal substance as opposed to Sotasorb. Sotasorb is irritating to the airways when it breaks down, and that's not true with the calcium carbonates. Multi-parameter monitors. The animal will not stay asleep. And if I showed you these different screens from these multi-parameter monitors and asked you which animal was hard to keep anesthetized or wouldn't stay asleep, well, I would tell you right now, it's this animal in the upper left and this animal in the lower left, as opposed to this animal in the upper right. And the reason I know that is by looking at what's referred to as the capnogram. Here the animal breathes in. The CO2 falls because there should be no CO2 in the inspired air, and then the animal breathes out. And when they breathe out, the CO2 rises because now you're seeing gas, which is coming from the respiratory ducts in the alveoli that is equilibrated with the blood that's returned to the heart and has CO2 in it. So when they breathe out, that's passing by a sensor, which gradually reads and increases to the peak amount of CO2 in the exhaled air. So at the end of exhalation, you see the highest CO2. That's why, again, it's called end tidal CO2. This animal is taking breaths that are intermittent and shallow. In fact, the animal's panting, which means that the majority of what they're breathing is dead space gas. That is to say, they're breathing in the fresh gas and then breathing it out right away. And by the same token, this animal isn't breathing frequently enough. Here it's almost apneic, and then it's taking a shallow breath and finally a deep breath. But these, let's say, abnormal breathing patterns lead to an average of hypoventilation from the standpoint that the animal, when they do breathe, may end up taking relatively normal breaths, but the majority of the breaths are subnormal. So even though the end tidal CO2 value might not be that bad, the rate's particularly low, number one. And number two is you can tell that there's something not right just by looking at the capnogram. That is the graphic representation of the end tidal CO2. So the pattern of these end tidal CO2 breathing patterns are important. It's like the capnogram is like the electrocardiogram is to the heart, but the capnogram now is a graphical representation of what's going on in the lung. So abnormal breathing patterns during inhalant anesthesia can be responsible for an animal waking up or arousal during anesthesia. The other thing is breakthrough pain. When you might be doing a particularly invasive surgical procedure, there's a mass being removed from this dog's maxilla and part of its mandible. What you want to do is make sure that you have adequate analgesia on board, and this might include ultrasound-guided nerve blocks. I'd recommend everyone to do to take a course on ultrasound-guided nerve blocks. You can see that this animal has some dead space because here they're breathing, and you can see the area expanding and contracting. But this was the dog on recovery, and at least for breakthrough pain, we were talking about the use of drugs like fentanyl and remifentanil based on their potency as analgesics. For more caudal surgical procedures, you may consider an epidural with bupivacaine and morphine. So what about airway complications and hypoventilation? That was another mishap or problem that can occur during anesthesia. Well, the first thing I would say, always pre-oxygenate an animal. So you need a minimum of about 5-liter flow rate for a period of about 3 to 5 minutes. Why? And make this a practice that is on all patients. That is, you can't do it intermittently, because if you start doing it intermittently, that is on some patients and not on others, then what ends up happening is you start to miss animals. That is to say, people are in a quandary. Well, should I do it or not? Well, the easy way to get past that is just do it on every animal. Why? Well, first of all, there are going to be some animals, particularly older animals or brachycephalic animals, dogs or cats, that will benefit from it more than others. If they're properly sedated, they will tolerate the mask, as opposed to if they're not tolerated, properly sedated. So that gets you past that particular aspect. But the real reason is this: how long does it take an animal to become cyanotic? And that is, if they're not breathing, it's usually about a minute or so, sometimes up to a minute and a half. But if it's a brachycephalic, or an animal that has issues associated with oxygenation of venous blood when it returns, it can happen in about 30 seconds. Now, if you pre-oxygenate them, you've actually, and if they're properly pre-oxygenated at 100% oxygen at a flow of at least 5 liters per minute, some people use 10 for 3 to 5 minutes, you've got anywhere from 5 to 7, some people say even 7 to 9 minutes before they will deoxygenate. So it gives you time, particularly if this animal is difficult to oral tracheally intubate. So make it a practice to pre-oxygenate every animal, and that then avoids the issue of cyanotic animals that may, particularly if they're old and frail, develop issues associated with hypoxemia. That is, things like tachycardias, things like arrhythmias, sometimes even things like collapse. And this is particularly true if they're brachycephalic. And here's an example of that, because sometimes you open these brachycephalic's mouth and all you see is a sea of pink. And upper airway obstruction is a problem in these animals. They're actually notorious for it. You can tell when you're set up for the problem in the first place. If you listen to this, just because the animal snores, you already know that this animal has a problem, whether it's in their upper airway or in the nasal turbinates, or whether in fact it's with the larynx. They often look like they have an atretic larynx, as well as the laryngeal cartilages don't seem to abduct. So you want to make sure that you get these animals properly pre-oxygenated. Cats, laryngeal spasms, so always make sure to use some kind of local anesthetic cream. We use these LMA atomizers, and we use them over and over again. And the reason is it creates a better distribution of lidocaine over a wider area, as opposed to using a 25 gauge needle on a tuberculin syringe. These atomizers are easy to purchase and don't cost much, and you can use them over and over again. Never use a mouth gag in cats because of potential occlusion of the maxillary artery and postoperative blindness. So we always use a wedge or some type of speculum that can be set to a certain, let's say, width, so that this spring doesn't continue to open the animal's mouth wider and again occlude the maxillary artery. Breathing. Again, remember, you don't want to over-ventilate these animals, and that means primarily watching your positive negative pressure gauge and trying to keep that pressure somewhere around 15 to 20 centimeters of water. Again, your circuit, your anesthetic circuit, so it should be able to hold at least 30 to 40 centimeters of water. So we take them up to 40, but we don't do that usually or ever when the patient's anesthetized. I've gotten pretty used to using ventilators for procedures, let's say somewhere over a half an hour, certainly over an hour. And the reason is that helps me to ensure that I give the same breath at the same frequency throughout the anesthetic procedure. That means, like in this instance, that the delivery of the inhalant anesthetic is like giving it by constant rate infusion. So remember that the drug delivery system for an inhalant anesthetic is the lung, and you want to make sure not to overinflate the lungs, as well as deliver adequate amounts of inhalant anesthetic by giving them a constant tidal volume, a constant volume. Because if you give them too little, that means that there's a greater fraction of ineffective or dead space ventilation, and it's more likely that the animal will wake up. Well, then we get to the pop-off valves and pop-off related problems. Well, pop-off valves, particularly the screw type, are the instrument of the devil. And at this particular point in veterinary anesthesia, if you have one of these, give it away. You'll be doing yourself a favor, or unscrew it so that it can't, and maybe weld it there so it can't be screwed shut, because you're asking for problems with this type of pop-off valve. What are you going to do, though, if you want to give them a breath? Well, first of all, the reason you don't want the pop-off valve closed is because sooner or later, you end up producing something like this. And you can see all the subcutaneous air, as well as the hearts being lifted off the sternum, that this animal has developed a pneumothorax, as well as this crepitus associated with subcutaneous air. So what is this? This is basically the result of a closed pop-off and a rupture of a small airway in the lung. And this is the pulmonary barotrauma. At its severest, it can end up potentially even killing the animal. How do you avoid that? Well, you get one of these little devices, and they cost you about $15 to $25. You can buy them through Smith Medical, which is the major distributor. Leave the pop-off open, weld it open, and if you want to give them a breath, you just push down this button, and that closes the circuit long enough for you to squeeze the bag. But the second you let go, the circuit's open and the circuit pops off. Now, there are fancy pop-off valves. There are a lot of them, but they're more expensive as opposed to introducing this into the exhalatory limb of the anesthetic circuit. And again, these are the different devices that are sold by Smith Medical. And again, I'll make my PowerPoint available. You can also buy these little alarms. That is to say, this hooks on to the exhalatory limb of the anesthetic circuit. And if the pressure, and you can set this, rises more than wherever you set it, we set it to about 25 centimeters of water, then an alarm goes off. So here's if we want to give them a breath, we push down on the button, squeeze the bag, and then the second we let go, it's an open circuit again. And if for whatever reason something else is causing the circuit to obstruct, this thing starts chirping at you or beeping so that you know something's not right. Well, one of the things that you should think about as far as monitoring, and it's become my favorite monitor, is end-tidal CO2. Why is that? Because it'll tell you more than you ever wanted to know. This is a device that you need to learn how, and your staff needs to learn how to use, because I feel that it's better, quite honestly, than arterial blood pressure. Not that the arterial blood pressure is bad, it's a good thing to get, because you can feel a pulse, a femoral arterial pulse, or some other pulse, a digital pulse, in most animals. And once you become skilled and familiar, you know whether the pulse is good and therefore blood pressure is good or not. In order to even feel the pulse, the mean blood pressure has to be above 40, and some people say 50 millimeters of mercury. That's somewhat animal dependent, but again, that tells you that, the blood pressure isn't zero if you can feel a pulse. And if it's a good, strong pulse, then it's usually up around 70 or 80 millimeters of mercury. The thing that you can't see, however, or measure unless you have a device is the end-tidal CO2. And you say, well, what about the oxygen? Well, you know when the animal's becoming, quotes, injected, or the animal's starting to look, let's say, a little, the mucous membranes are a little too reddish, or in fact, they're starting to become cyanotic. Now, part of that's dependent on the animal having at least a normal hemoglobin and PCV, but if this animal was certainly well enough to do surgery in the first place, if they start to develop a grayish or bluish discoloration, you know things aren't right. But you can't see CO2, and CO2 has important implications, not only with regard to ventilation, but with regard to the cardiovascular system. So end-tidal CO2 turns out to be my favorite monitor right now. And basically what it's measuring is when the CO2 returns to the lung, it's at higher concentrations in the blood than in the alveoli, diffuses into the alveoli, and when the animal breathes out, the concentration gets higher and higher and higher until the end of expiration at point C here, and then the end tidal just before the next breath, he's breathing in fresh gas that has no CO2, it falls almost to zero or close to zero, and then the cycle repeats itself with the next breath. So what you want to see is not only a numerical value of what the end tidal CO2 is, but a picture or a capnogram of the end tidal or the CO2 concentration in the exhaled air. So why do you want to know the end tidal CO2 during anesthesia? Well, one, it lets you know whether the endotracheal tube's in the right place, or has been dislodged, or is kinked, or is blocked, or has actually even been pulled out. Number two, it lets you know when and how well the animal is breathing, whether the animal is hypoventilating or whether the animal's hyperventilating. It lets you, well, or apneic. It also lets you know if the animal is breathing adequately during spontaneous or manual mechanical ventilation. That is to say, you can adjust the end-tidal CO2 based on the ventilator settings or on your manual ventilation of the animal. And that's important with regard to maintaining a stable state of anesthesia. It lets you know if the animal is rebreathing CO2. Let's say the CO2 doesn't fall back, the end-tidal CO2 doesn't fall back to near zero. Then something's got to be wrong with your anesthetic circuitry. That is to say, the one-way breathing valves aren't working properly. And then it lets you know the animal's blood flow or cardiac output. And the reason is because if everything's stable, and all of a sudden, that is, the breathing's been stable because you've been bagging them if it's a higher risk patient or the animal hasn't been breathing normally, or if you have them on a ventilator, if you've been breathing them and the end-tidal CO2 was staying right around 40, maybe it was 35 in that animal, maybe it was 45 in another animal, but you're within the normal range if you're in, quite honestly, between 30 and even 45 or 50. You don't really have to worry too much about it. But if you're breathing them and all of a sudden it starts to fall, then usually that's a sign that the animal is becoming either hypotensive. If you're not measuring blood pressure, that's an indication that that might be occurring. Or at the very least, it means that their blood flow is going down, even if pressure is staying stable. And the reason for that is that CO2, the only way it can get back to the lung in the first place is via blood flow from the peripheral tissues. So if everything's been stable and you've been ventilating or the animal's on a ventilator and the cardiac output starts to fall, then the end-tidal CO2 starts to fall. And because of that, it's used during CPR to determine the effectiveness of cardiopulmonary resuscitation. If you read the RECOVER guidelines, you'll see that one indication of good CPR is that the end-tidal CO2 goes from zero because there was no blood flow during cardiac arrest, so there's no CO2 returning to the lung, and finally starts to rise when you do good CPR or chest compression, because in fact now the CO2 is being returned to the lung and is being ventilated off. So last but not least, it helps you maintain a stable anesthetic plane because you got normal ventilation. And this is during inhalant anesthesia. So all these things become important. Well, what's a good end-tidal CO2 device? I actually have one of these I keep in my pocket when I'm visiting practices, because what does it give me? It gives me the end-tidal CO2, it gives me the respiratory rate, and it gives me the capnogram, which is equivalent to or analogous to the ECG of the cardiovascular system. This is the analog or graph of the lung. So you can use it to interpret problems in the lung, just like you use the ECG to determine problems in with the heart. This is the distributor nationally, and this is his email address. A good end-tidal CO2 device will cost you somewhere between $800 and $1,000. And as far as end-tidal CO2 devices are concerned, I like the mainstream ones, not the kind with the little tube that comes off and goes to some monitor that sits on a table somewhere. This hooks right in the circuit outside the endotracheal tube. And you can see that this animal, you could say, was a little bit hyperventilated because the end-tidal CO2 is lower, but there's a respiratory rate, and here's a capnogram down here. This is during spontaneous ventilation. We're not going to talk a lot about how an end-tidal CO2 device works. I would just say they're very valuable, particularly in higher risk patients, let alone getting used to them in normal healthy patients and how they work. These devices teach you as much about anesthesia as they do warn you when there's something not going right. Here's examples of different capnogram waveforms that indicate different problems. Here's the sudden loss of the capnogram, which means the ET tube became disconnected, dislodged, kinked, or obstructed. Decreasing ETO2, end-tidal CO2, there might be a leak in the cuff. The tube might be displaced into the laryngeal area or hypopharynx. Here's CPR. Again, if there's effective CPR, then the end-tidal CO2 should increase. Sudden increase in end-tidal CO2, that would mean a return of spontaneous circulation during CPR. Bronchospasm, usually you don't get a square wave, you get what's called the shark fin. That is, sometimes this becomes triangular, which indicates airway obstruction. Then there's hypoventilation, high end-tidal CO2, hyperventilation, low end-tidal CO2, and then, periods of apnea. Last but not least, if you see a rising baseline level of the end-tidal CO2, it usually means you have exhausted CO2 absorbent, or you've got some kind of leak in the exhalatory valve where the animal is rebreathing their exhaled gas. So just like the ECG tells you there's something wrong with the rhythm of the heart, the capnogram tells you there's something wrong with the ventilation, and it's an indication that you need to do something sooner rather than later, because high end-tidal CO2 can produce anesthesia by itself. It can predispose to acid-base imbalance, particularly respiratory acidosis, which when it gets severe enough, actually leads to poor tissue metabolism, poor cardiac function, and even the onset of cardiac arrhythmias. So all of these things are important. And maybe the thing that's, let's say, not talked about enough is remember that CO2 is a vasodilator. Some of you may have done some large animal practice or aware when you were in veterinary school, they say, well, how do we send pigs to slaughter? Well, one of the things they do is they walk them through a CO2 pit so that they vasodilate. So when they're slaughtered, they bleed out faster or more completely. And why is that? Because CO2 is not only an anesthetic in itself, it's a massive vasodilator. So one of the reasons the animal might have been hypotensive, besides the inadvertent administration of too much anesthetic drug, is the fact that they vasodilated due to the fact that they weren't being properly ventilated. So again, Here's an indication. Here's an animal that's on a ventilator who got light, and you can see the bag jumping around. Well, those are the ventilator bag wiggles, and you can see that here in this capnogram. And this capnogram is just starting to occur, which means, if nothing else, it tells you if the animal's starting to breathe on its own, then before it develops this, there's an indication because you can interpret the capnogram. So if you took a quiz and I asked you, well, what are these various capnograms? And I showed you a lot of them earlier. Well, a straight line would mean they're apneic. A shark fin would mean there's some kind of endotracheal or airway obstruction. A notch would mean that there's spontaneous breathing that's beginning to occur. Sometimes you see these oscillations associated with cardiac contraction. That means actually this isn't too bad. You can see the inset here. That means they got good cardiac contraction. So that's not anything too bad, but it means, again, you might need to alter your anesthetic depth. And then you see this one with this step, and that usually means there's a problem with the airway or endotracheal tube placement. Maybe it's working its way out, the endotracheal tube is working its way out of the trachea. Then for CPR, if there's no blood returning to the heart, then the end-tidal CO2 stays low. And if you're doing cardiopulmonary resuscitation, if it's effective, then you start to see the end-tidal CO2 rise with the return of spontaneous circulation. So these end-tidal CO2 devices turn out to be very helpful. Hypotension and cardiac arrhythmia is another common problem. Well, what can cause hypotension? Well, hypothermia can cause it. We already talked about hypercarbia can cause it. Hyperkalemia can cause it. Hopefully you have an indication of that beforehand based upon the animal's comorbidities. And cardiac arrhythmias can cause it. Now, you could also say heart failure can cause it, but again, you should have some indication of that ahead of time, and usually do, either because the animal's on medications, there's some history of that, or you've done an adequate, let's say, physical examination, and with that in the history, you have something that tips you off. Sometimes hemorrhage can cause it, but hemorrhage doesn't have to. Why? Because there's absolute hypovolemia that can be caused by dehydration or actually hemorrhage, controlled or uncontrolled. And this could be in your trauma animals. You got to, or animals, let's say, that have developed, let's say, hemangiosarcoma, where they're bleeding into the abdomen. This is a topic into itself, but the more common problem during inhalation anesthesia is relative hypovolemia. That is, if the blood volume is contained within, a container of a certain size, based upon the effects of the injectable inhalant anesthetics, that container is made bigger. So that's what's meant by relative. You only have, in dogs and cats, a certain amount of blood volume. In dogs, it's around 80 mLs per kilo. In cats, it's probably closer to 55 or 65, somewhere in there, mLs per kilo. But if you make the container bigger, the amount of blood for the size of the container is inadequate. So you haven't lost any blood, but there's less blood for the size of the container, so you have a relative hypovolemia. And all inhalant anesthetics do that to some degree in a dose-dependent manner. Here's an example of a hemangiosarc and some formulas that help you determine how much blood loss. Suffice it to say that most of the time animals can tolerate, without too much problem, about normal healthy animals, about 20% blood loss without their blood pressure or cardiac output going down. That's normal healthy animals. Anesthetized animals start to show a decrease in blood pressure and cardiac output when they lose about 15% of their blood volume. So regardless of those procedures are pretty bloody, or where the animal has already lost some blood, you need to be thinking about volumes in the neighborhood about 15% of the animal's blood volume before you start thinking, that tip you off as to why, particularly in combination with your anesthetic protocol, this animal might be acting hypotensive, have prolonged capillary refill times, and have poor color. So again, 10 to 15 mLs per kilogram is usually under anesthesia the most they can tolerate before bad things start to happen. In normal healthy animals, you'd say, well, what's the treatment for hypotension? Usually the first response is always fluids. Well, fluids are only partially helpful. Baseline fluid rates need be no more than 3 to 5 mLs per kilo per hour. Rates faster than this, all you're doing is causing more fluid to accumulate in this interstitium. That is, the old rates of 10 mLs per kilo per hour, and some people even said 20 mLs per kilo per hour. All you're really doing is making the animal more edematous. If the animal is normal and healthy and has normal effective pressures, those rates at 10 to 20 mLs per kilo do nothing but produce, let's say, interstitial edema. When the animal's hypotensive, however, more of that fluid stays within the vascular compartment and helps maintain blood pressure and blood flow. So how can you, let's say, get an index of when you need fluids? And the answer to that is to use a pulse oximeter that gives you an additional reading, and that additional reading is called the PVI, or Pulse Variability Index. And again, there's only a few monitors that do this, and this is another Masimo monitor called the Radical 97. And here's the actual curve on this dog. You can see it's looking at the a plethysmographic waveform from the sensor on the tongue. And you can see the animal's SpO2, that's the pulse ox value. You can see the animal's heart rate, but you can also see the pulse variability index. And a normal pulse variability index, which means the variability in these pulses, gives you an indication of whether the animal needs fluids. Said another way, when that value in dogs is greater than about 18 or so, and in cats greater than about 20, it's usually an indication of vasodilation and the need for fluids. But what should be your first response when this occurs? And the answer is turn down or reduce the amount of anesthetic that's being delivered. That is, your first response should be to reduce the amount of anesthetic. So hypotension can be caused by a lot of things. Hypothermia can cause it. Hyperkalemia can cause it. Hypercarbia, too much CO2 can cause it, and too much anesthetic can cause it. So if it's hypercarbia, try to reduce the amount of CO2 by better ventilation. If it's hyperkalemia, then you're going to have to try to do something to reduce the amount of potassium, but that's hard to do it fast. So how is it treated? It's usually treated by giving a calcium solution, like calcium gluconate or calcium chloride. If it's hypothermia, it's make them warmer. But if you got the combination of hypothermia and hypotension, you're in trouble. So you have to turn off the anesthetic. So this is just an example of the pulse variability index, the PVI, in a normal dog and in an abnormal dog. Here it is up to 31. This is an indication that the animal is vasodilating from some cause. And the most likely cause, if they're not hyperkalemic, if they're not hypothermic, if they're not hypercarbic, is too much anesthetic. So you reduce the amount of inhalant anesthetic and the animal begins to respond. What next? Well, that means you need to treat pain, because that's usually what's happening associated with the surgical procedure. So when you get in that tough situation between not knowing what to do, what you need to do is to reduce the inhalant anesthetic and introduce more analgesics, which means usually fentanyl as intermittent fentanyl boluses, or alternatively to start a fentanyl infusion. And we showed you those dosages earlier. So next I want to talk about cardiac associated arrhythmias, but this is a two-part session. We've already talked for about an hour now, an hour and 5 minutes. So we're going to stop here and we'll begin part 2 at a later date. But I hope this has been helpful to you with regard to the common problems and mishaps and mistakes associated with anesthesia. And I look forward to your questions, and we'll have part 2 at a later time. Thank you.
Thank you, Dr. Muir, for your presentation. Certainly, if anybody has any questions, please post them in the question and answer section, and we will share them and do our best to have Dr. Muir answer those questions for us.
Anthony, you're going to have to read them. I can't get the questions and answers on my.
Not a problem. Not a problem.
Nobody has any questions.
Yeah, it looks like you've done a very thorough job. So we don't have any questions right now. Like I shared previously, I'll send a follow-up email to everybody. In that email, we'll share Dr. Muir's
I have some questions.
contact
Anthony, I have some
information.
questions.
Yeah, I got it.
Okay.
1 second, Larry. So one question that came up was, I heard that it takes a while for injectable Rimadyl to get on board. How long do you feel that it takes?
I really don't know what the origin of that statement is. I've heard it before, but the answer is any injectable non-steroidal should begin to work almost immediately. Now, will it work to its, let's say, peak effect? And the answer to that is it depends upon how bad the inflammatory process is. If the inflammatory process isn't very great, again, it doesn't seem like the non-steroidal anti-inflammatory is working very well. If the inflammatory process is, let's say, more active, then the NSAIDs seem to work better. So when you have animals that come to you that already have, let's say, infected tissue, where you'd expect an upregulation of, let's say, COX activity, cyclooxygenase activity, and therefore a lot of inflammatory mediators, when you give a NSAID, you usually see a pretty pronounced effect. You feel happy with its effect. Another reason I don't like giving them before surgery is because of their anticoagulant effects. That's particularly true, for example, with those that have COX-1 versus COX-2 activity. We're not talking about NSAIDs in detail here, but drugs like aspirin, which isn't used all that frequently, but is still pretty effective. You wouldn't want to give it before surgery. But the bottom line is most of the drugs, except for one, furocoxib, have both COX-1 and COX-2 inhibitory effects. So most NSAIDs that are out there have the potential to interfere with coagulation, which you don't want to do intraoperatively. So again, that's another argument besides their potential renal effects, because all NSAIDs are toxic to the kidney, at least all to date, because of the importance of PGE2 in renal tubular function. I like to make sure that the animal's recovered, has good blood pressure, good blood flow, and let's say has clotted fairly well before reintroducing a non-steroidal.
Thank you. Another question or request that came through is, can we get the website again for the checklist for anesthesia machines, please?
Well, I can do that by backing up, I think. So let's see here. I'll go back to the beginning. I'm madly pushing this little button to get there. Yeah, the anesthetic checklist. If you do actually even do a Google search for anesthetic checklists, you will find a number of them for veterinary use. This one is a fairly comprehensive one that I liked. And it was made by the ABA, and that's the European Society for Veterinary Anesthesia. but this will give you a comprehensive checklist of what you should do before you start an anesthetic case. And you can take from it whatever works best for you in your practice. There are some key points, particularly doing the leak test, as well as making sure you have the CO2 absorber checked and make sure it's sealed, as well as making sure you got enough anesthetic in your vaporizers, and making sure your one-way valves are working, but it's all there.
All right, thank you. All right, okay. Another question is, you talked about hydromorphone and Dex or with midazolam. Do you have any opinions on hydromorphone and acepromazine?
Well, it's another excellent combination. I would say, you know, the way that veterinary anesthesiologists are being trained today, that is the new breed, in association with anesthesia, they're usually acepromazine isn't part of the mix. I think it's an excellent drug. You just have to know when to use it, when not to use it, and some of the issues associated with its use, if you're going to use it, is keep the dose, let's say, reasonable, not too low, but certainly not too high. Dosages in the area of, let's say, 0.125 up to even 0.2 are fine. And it'll keep the animal calm usually for several hours after surgery. When do you want to avoid it? Well, you want to avoid it in animals that are, let's say, hypotensive, because it's a known vasodilator. Some people get concerned because it causes platelets to accumulate in the spleen, but it usually doesn't interfere to any great extent with clotting. And then there's always the old school idea of that it lowers seizure thresholds and predisposes to seizures. Well, that is probably true in animals that have certain types of seizure disorders, not all types. And in fact, there's been a couple of studies that where acepromazine has been given to dogs with, let's say, hereditary induced seizures. And in fact, the seizures were no different whether they were given ACE or not. And in fact, some instances were suppressed. Those papers were published in the American Animal Hospital Association journal. So the issue with seizures was primarily an issue in the distemper days, and how relevant it is today has not really been studied very well. If you have any concern, that is, you have an animal that has seizures, then don't use acepromazine. Again, today people are thinking about or replacing acepromazine with trazodone, but ACE hydro isn't a bad combination in an otherwise normal healthy animal, because you get good calming as well as good analgesia, hydro being about 7 times more potent than morphine as an analgesic, and not inducing histamine release, which morphine does.
Okay. A couple more questions here. This is a good one. How can I convince the veterinarian to stop tank inductions and use alfaxalone? I've provided all the information I can find on the medication, and there is still a huge hesitation to try it.
Well, you're talking about, just to use the phrase, teaching an old dog new tricks. Quite honestly, the only real good argument that you have is the safety. Sooner or later, somebody's going to have a problem with boxing a cat down, or a small animal, a dog. And the reason is, regardless of anything else, and even, people have become particularly skilled at this, is that those animals have a greater tendency within that box, because you're dependent on very high concentrations over a very short period of time to produce unconsciousness. They are usually more hypotensive and hypoventilatory than you need to be. The other issue is this, which again, in today's world, and depending on let's say, the staff, it can become a real problem, and that is, you're contaminating the environment with the inhalant anesthetics. And remember, all inhalant anesthetics are profound vasodilators, particularly to the cerebral circulation. So sooner or later, you're going to come across somebody in the practice that in fact develops headaches associated with the amount of inhalant anesthetic in the environment. In all my years of teaching, I think I came across this where it was a real significant issue, probably in about, let's say 15 to 20 students. That is to say, even though we were being careful in scavenging most of these gases, when these students would inhale, or let's say breathe, the residual amount of inhalant anesthetic in the operating room that wasn't being scavenged, they would develop a headache. And if you're in a surgery room most of the day and breathing inhalant anesthetics, don't be surprised if in fact you start feeling like your head's starting to get more congested, or you start develop what you think is a sinus headache. It may in fact just be the vasodilator effects of the inhalant anesthetic. So I'd say one, environmental pollution, and number two, just the fact that all inhalant anesthetics have potential toxicities associated with them, even if they're minor. And three, I guess, is don't forget, to produce the anesthesia, you have to have high concentrations over a short period of time, and that leads to an increased incidence of hypotension and hypoventilation in the animals that are being boxed into an anesthetic state.
Okay, thank you. Another question is, in your opinion, is blood pressure the best indicator for anesthetic depth if you do not have a way to measure CO2?
Is blood pressure the best indicator of anesthetic depth? It's an indicator, but I would say it's a later indicator. That is to say, there's no question that there's a dose-dependent effect between the anesthetic drug, whether it's injectable inhalant, and the blood pressure. That is, the more you give, the lower the blood pressure. How that relates, though, to anesthetic depth, which is really the concentration of the drug in the brain, is not always a direct relationship. Yes, the more anesthetic you give, the more anesthetic in the brain, the more unconscious you should become. But they're not necessarily synced together, that is, blood pressure and unconsciousness, with time. That is to say, sometimes the blood pressure falls before the animal's totally anesthetized. So they're acting awake and yet they're hypotensive. And other times the animals could be, let's say, fairly deep, but the blood pressure could be very normal. So the syncing between the two isn't what it should be. So you'd say, well, how do I get around that? Well, you have to monitor something. And since you can't monitor the CNS depth of anesthesia that closely, unless the animal is actually moving or quivering, well, you have to monitor blood pressure. So you got to use all your signs. You got to use the clinical signs that tell you that the animal's not responding to noxious stimulus, that is to surgery or pain, and you have to combine that with the animal's blood pressure, if you can measure it. That is, if you do not have end-tidal CO2. Now, that doesn't mean that you won't get into situations clinically where the animal is adequately anesthetized, but they're hypotensive. So you reduce the anesthetic, now the animal isn't hypotensive, but now they're awake. So what do you do then? Well, try to keep them from getting hypotensive. Don't give any more inhalant anesthetic because that will make them hypotensive. And now depend upon your analgesics like fentanyl to remove the majority of the pain so that the animal doesn't respond adversely to the surgical manipulation. So short answer, I guess, is yeah, if you can only monitor one thing, monitor their pressure. But I would say, start looking for the ability to monitor end-tidal CO2, because that'll be a better guide with something like PVI. You say, well, maybe final response is, well, what do they do in human medicine? Well, what they do in human medicine is they monitor the EEG. And you say, well, I remember that in vet school. That was, a horrible thing to have to go through. You had all these pins sticking in the animal's head. Well, that's been refined, that now from stick-on electrodes, 3 stick-on electrodes, you can get an indication of the animal's anesthetic depth, or the human's anesthetic depth, by what is called the bispectral index or the cerebral state index. And what it does is it gives you a number between 0 and 100, 100 being 100% conscious, 0 being basically flat line. And they know in human medicine, using these devices, that when you have a number like 50 or 60, you're in a surgical plane of anesthesia. So that's where human anesthesia is. We're just not there yet in veterinary anesthesia. So we have to depend more on clinical signs, and let's say how good our fingers are in detecting a pulse, how good our eyesight is at determining color, how good our fingers are in determining capillary refill time, et cetera, et cetera. But of all the monitors that you have, my favorite is end-tidal CO2. And since I can get that plus the pulse ox, plus the heart rate, plus the PVI on the Radical 97, then that's the monitor, that's my favorite monitor.
Okay, thank you. And one more question we have is our clinic only stocks alfaxalone and no longer carries propofol now that its shelf life is longer. Do you think it's okay not to have propofol in stock anymore?
No, I think it's fine. You probably I don't know if you readjusted your, I don't know what your pre-anesthetic medication is, but as long as your pre-anesthetic medication includes things like a benzodiazepine and an opioid, possibly an alpha-2 in those animals that need it, and you've worked out that so you're satisfied with your level of sedation in different animals, from young to old, from normal healthy to, let's say, giant breed dogs that may have some infirmities, and you've worked that out, then yeah, I think having alfaxin as your principal injectable anesthetic is fine. Remember that all GABA A agonists, and alfaxin is one, but so is propofol, are do have excellent anti-epileptic activity and excellent muscle relaxant activity, even though you'll see mild clonus, and occasionally some animals develop seizures, which again should be treated with an additional dose of a benzodiazepine. But with good pre-anesthetic medication, those issues are minimal.
All right, well, I think that's all the questions we have for tonight. So again, thank you everybody for joining us tonight. Thank you, Dr. Muir, for all the education this evening. I will follow up tomorrow with an email. In that email, you'll have instructions and contacts for Dr. Berkowitz. Dr. Berkowitz will facilitate making sure everyone gets registered and accredited for the talk tonight. We'll provide some certificates after we submit that to RACE. And also, Dr. Muir is kind enough to share his email address. So if anybody does have any further questions, he's happy to provide even more assistance. So we'll be following up with you guys. Also, we'll look to, we've had great attendance at both meetings tonight. So we're going to look to putting on part 2 of this educational series, and we'll certainly share that date with you once we get that scheduled. But most importantly, thank you, Dr. Muir. Thank you, Dr. Berkowitz, and thank all of you guys for attending this evening. I hope you enjoyed it as much as I did.
Thank you.
All
Perfect.
right. Well, thank you, everyone, and have a great evening.
Great job, Bill.
Thanks.
Thanks.